Movement is your dog's language. Learning to understand it changes everything. Welcome to Inside the Canine Athlete with Jana Gams and Dr. Sherman Canapp.
Today, we're doing something a little different. We are not only talking about a condition, we are following a real case. The story of Venom, an athletic dog with a medial shoulder problem, and his journey from the first subtle signs through diagnosis, treatment, rehab, and also return to sport. And for this opportunity, we are joined by Chiara Sandroni, Venom's owner and handler. So hi, Chiara. Thank you so much for joining us.
Thank you for having me.
This case, I believe, is also special for us because in many ways, Venom's case is what brought the three of us together.
Yes.
So Sherman was involved from the sports medicine and diagnostics and treatment side. I later took over the rehab and return to sports phase. And Chiara, you were the person living the whole process with Venom every single day. So it's a pleasure to have you here because we would love to hear this story through your eyes. So before we dig into that shoulder joint itself, can you perhaps introduce Venom to us? Like, who is he? What sport does he do? And what kind of a dog he is?
Okay, so Venom, he's a border collie. He's now almost 5 years old. He was just over 3 years old when this whole thing started. He is, I call him an adrenaline junkie. He's always been a psychopath. He just does everything full speed, full on, you know. So I guess looking back, shocking that he got hurt, right? But we train agility, obviously. We're just about ready to go to EO tryouts. And this day, towards the end of January of 2025, he had a beautiful training, very technical course, fast and everything. He does amazing. I'm super happy. You know, do a little bit of cool down. I say a little because later on we're going to talk about how I learn how important that stuff is. And then he goes in, he's great. I teach my first class, take him out, and he's off. Like, not limping, but off. So I'm like, you know, you always check the pads, the nails, and that stuff. He moves off, and he was fine. But that was the beginning of these, let's call it a nightmare, because honestly, yeah, it was a long journey. So that.
So that was kind of like the first thing that made you feel that something is really not quite right?
Something was off.
Mm-hmm.
I honestly, in a way, at first thought kind of nothing of it. You know, I mean, I do sometimes tend to go to the worst case scenario, but also in a situation like that, I'm like, that limp, let's call it, lasted a few seconds. So I just thought nothing of it. And then I remember, I don't know, 2-3 days later, I train him again and same thing happens. So I'm like, hey, so we have a chiropractor. I took him to the chiropractor. She thought it was his wrist at first, a little locked up. So, you know, she said, just give him a week off. Fine, good, week off, train him again, same exact thing. And it was always after the cool down, after being in a crate for a couple of hours, that's when he would show it. And it's never been a super like limp. It's always been very like little things. Mm-hmm. So I took him to my regular vet. Obviously, they thought I was crazy because by the time I would take him to the vet, the dog was perfectly fine. So, you know, it just keeps going on. And I train him again. He does the same thing. So I'm like, okay, this is not cool. So I took him to, it's a rehab vet that we have here in Michigan. She does all of her things. She can't really see anything. She said, let's get a set of x-rays. So we x-ray from the nose to the tip of the tail, okay? And she's like, listen, I'm not sure. So she sent me to an orthopedic vet. So I go to this orthopedic vet. He does his first evaluation. He thinks it's a toe. So I'm like, fair. Now, the thing with Venom is that he doesn't show pain like some of my other dogs do, you know? So you can just move him and do everything you need to do. And I think the most we saw was like him squeezing his eyes a little, right? And so he thinks it's a toe. Cool. I'm still not, convinced. I think there's something wrong. So we did a CT scan and MRI. And he can see, yes, so inflammation on the fourth digit and some calcification on his right shoulder. So we did 3 sets of PRP, kind of, if I remember correctly, like a month apart. In the meantime, it's rest. I do believe they told me crate rest, so we did a lot of crate rest. And then I start underwater treadmill and laser every week. Time goes on and we start doing agility again, like very slowly, 8 inches jump, just a straight line, or introduce tunnels, just slowly. And then I remember doing a little sequence, I don't know, 6, 7, 8 obstacles, limp again. So at the time to these days, I was posting on Facebook. And so on Facebook, people said, you should contact Dr. Canapp. And so that's when then I met him. And I started, noticing things that I guess I assume were either on my side, lack of training, like collections, right? What's a collection? He don't know. Soft turns. He was, I have to say, pretty good with backsides and weave entries, even though here and there I miss weave entry. Bars, he was pretty good. Most of the time he would drop bars either because of my timing or just, I want to say him not caring, like, okay. But one thing I noticed is that he would try, if I would cue a right or left that for him were tight turn to the right or tight turn to the left, he would try to go backside instead. I guess he had found a way to turn his body on those backside to not hurt his shoulder as much. While to compensate, while on a collection, he probably couldn't do it. So that, and I do remember, again, not thinking that he was hurt, thinking it was a lack of training. I do remember doing specific training on collections that now I regret because I was probably hurting him, but you don't know what you don't know.
Exactly.
Right. So I just did what I thought was the right thing to do at the time. Let's put it that way. And then we did a phone consultation with Dr. Canapp. And I remember you asked me for everything I had. So x-ray, CT scan, MRI, videos, my impression, like what was my feeling of this whole situation, right? Because that is one of the things I totally appreciated, because up till then I thought, I don't know, nobody cared. That sounds tragic. But nobody really cared what I was thinking about my own dog. But I know my dog better than anybody else. I'm not trying to be, but I do. I mean, I live with him 24/7. I watch him. That feeling, I don't know, this might sound stupid, but that feeling to me, it's important. So I appreciated that you did care about that. And then I guess based off of what you saw, you said, you should come here. So we did schedule that appointment in August 12th. So I came down to, was it Maryland? No, yes.
Maryland. Yeah, Maryland.
Yes. And oh boy, that was something. My friend Lisa, she's an angel, because oh my goodness, like she heard it all. I do remember, I forgot to say, you also had me do Rocky Mountain tick test.
Yeah.
Something, right? Something about, maybe you can explain that, but something about inflammation.
Yep.
And he did test it positive.
Yep.
How, why, I don't know. But so we treated him for that for a whole month.
We'll talk about that. Yeah, we'll talk about that.
So we treated him. He was on antibiotic. Don't ask me to say the name of the antibiotic. That one there for a whole month. And then, yeah, we came down and we had the consult. Then we had the surgery 2 days later on the 14th. That was scary. Very scary. And do I keep going?
Actually, I would reflect back. Okay. And I was really like caught by your description of these early signs that you were noticing. Because oftentimes these shoulder issues are not related to a big single trauma, but they kind of like build up through time. So how about you, Sherman? When you heard like Chiara describing these early signs, like what stands out to you from a sports medicine perspective?
Yeah, man, there were so many things. First off, as an owner, you nailed it. Trust your gut. And and so many times one of the top lines is, everyone thinks I'm crazy. Literally on the intake forms, because everyone has this very long intake form, because I like you mentioned, I need to know your perspective. I need to get not necessarily inside the athletic dog, I need to get inside the athletic you, because I have to feel and see what you're feeling and seeing, which is why in a second we're actually going to show us, what are you feeling? We'll get Venom out. But the things, first off, she was working with an amazing team. The whole team she has in Michigan are incredible. The chiro, the physio, the surgeon, everyone did an amazing job. And they did find things. And remember, we talked about the toes, and they can have a dog become, clinically not sound or professionally not competing at the level that they should be, just because they have a jammed digit. And so absolutely they found that. And that can be a contributing factor. If your toe is off, it's a chain. And so if they don't feel stability or confidence in their feet, they're not going to engage the whole rest of that limb the way they're supposed to. And so that shoulder, I don't want to say the chicken or the egg, but you actually did so much for Venom in the fact that they did identify the digit. It sounds like we got on top of that. And they were seeing things in the shoulder. There was some suspicion of the shoulder. Your gut said something else is going on. And that's what allows owners to drive further forward and be their advocate for their canine athlete. And I think that's the important thing, is everyone has to trust their gut. You're not crazy. And it is like when you take your car to the shop, the squeak's not there, right? You take your dog in and you're like, oh, Venom looks amazing today. They're not going to believe me. They're not going to believe me. And you also nailed it on the head. They don't show pain. The challenge with a lot of these high drive dogs and these breeds, they aren't going to show you, oh my Lord, please stop doing that. This hurts. No, you're looking for, just like you described initially when they were looking at the digit, and all of a sudden pupils dilate, hold our breath, kind of check in. They just give you that little look like, hey, feel that. Those are the little subtle things. Most people just they blow by those, and they don't, because they don't go slow enough, or they even sedate the dog. So you nailed it every step of the way of what you were seeing, what you were feeling, and what you described in the ring is so important for people to understand that are listening to this. They're not lame. 99%, I would say 90+% of these dogs with these shoulder conditions, and we'll call it medial shoulder something. We'll talk about how we changed it from medial shoulder instability to syndrome to now even just describing it by the anatomy, like subscap or MGL, and we'll talk about what those are. But you kind of nailed it. What we see typically, whether you're agility or other sports, it's the turns. It's the turns. And when you were describing all of a sudden collecting and the tight turn or changing our turn or the way we would approach our turns, one direction or the other, I don't want to say this makes my life easy and my job easier, but I can tell by I watch a lot of film. I look at video after video. That's why I have you guys send all these videos in, because I'm watching in the ring. What are they doing? Where are they offline? Are they offline because of the handler? Or are they offline because of the dog? Or are they offline because of the course? And it was the course setup or the grip or the surfaces. There's so many reasons they could be offline. And so, but with your dog, it's not offline because of training. Your dog's not offline because we're not conditioned. Your dog's not offline because you're skilled, amazing trainer and athlete. So there was something else going on. So when I got a chance to look at the videos, I'm like, you're absolutely right. We are not turning a certain direction, and we're not turning there possibly because of X, Y, or Z. Okay, so my index of suspicion went up just from what you were giving me in the history of what you were seeing, and then being able to see tape and say video of all the videos. And owners always say, oh my Lord, I have some videos to show you. You're going to think I'm crazy. I'm like, no, I don't think you're crazy. I need to see as many as you can show me from different angles, different approaches, different obstacles. That's going to help us clue in, where is it coming from? Could it be a toe? Could it be an elbow? Could it be a shoulder? Is it the spine? Is it the psoas? Those videos are so helpful. So that's why I say to people, you don't know what's normal until you don't know what's abnormal until you know what's normal. So body mapping your dog and having tons of videos of your dog are so critical. And you did all that. You made my life so much easier.
Yeah. And I have to say, I video, and I'm grateful I do. I always video, well, other than competitions, even though he didn't do that many, but like my trainings, I always video them. And like watching on and on, like I noticed how many times he would fail, like going down on that shoulder. It's so quick though. It happens so fast that like he would, go down, come up, move on. He would fail coming out of tunnels and a bunch of stuff like that. That I always thought it was just him being, sorry to say stupid. That's probably the wrong way to say, but just like careless, because that's the type of dog. I told her I had to teach him not to use the wall to stop himself. Like dude would run full speed into the wall. Like who does that? Him, because he doesn't care about his body. So I never thought there were like something going on behind him acting the way he was acting. Well, most likely it's just he couldn't stand up. He couldn't hit in the wall. That's different. But, he couldn't. So that was like, you both taught me how to look at things a different way. Let's put it that way. But yeah, watching videos, like training your videos, like your training sessions. Wait, what? Videoing your training sessions. Yeah. It's like so important. And analyze those videos, like every step, every turn, everything. So important.
Yeah. So if you ask me back to the question of what really cued me in as to, are we going down the path of potentially the shoulder issue, the turns. The number, these dogs aren't typically knocking bars. The tunnel, the sequence, it depends on where the tunnel's set up in the line, going from the tunnel into a dog walk, or where, that can change. But the reality is the turns, because what happens is, they have this, what we call neuromuscular inhibition. They don't feel as confident in that shoulder. Okay. They don't have, maybe it's the strength, maybe it's the coordination, maybe it's the, I don't want to use the word stability, because they're not unstable, but they're not feeling confident in that shoulder. So to take that turn at the speed, especially the speed of Venom, if you watch these guys that do GP motorcycles, and they're dragging their knee, that's how Venom takes a turn. I've never seen a dog be able to go this fast through turns. It's incredible. But why that's important is because grip is so important then. And it was classically the history of taking the turn to the right. And so when we're going to the right, that left shoulder has to be so engaged and so confident and so strong. And if it's not, there's these little micro slides or micro instabilities or micro seconds where they're saying, I'm not able to capture this. And all of a sudden you see a drop, or all of a sudden you see, what did you just do? Or all of a sudden they're wider. Okay. All of a sudden you're like, what are you doing with your hind end now? Well, they're figuring out another way at speed to turn tight fast, whether it's a backside wrap or whatever you're doing. They have to figure out another way to manage this shoulder. So they're going to use other parts of their body, whether it's their spine, their hind, to be able to engage that left shoulder. So classically, the turn to the right is going to be that left shoulder if it's the opposite. But where this is critical, and we'll talk about this later, is that they can compensate, because this breed is so skilled, and Venom has no self-preservation. So what's going to happen is we say, well, I'm going to now change. I'm no longer using this one. What can I do with this shoulder? How can I now use this as my stabilizer, or use this to power through? And that's why in so many of these dogs, the other shoulder is already starting to have issues because of compensation. And but you nailed it. So yeah, so that was really what I took away from that great history, and all the videos you sent me were, okay, it's further up the chain. We have the toes situated. They did a great job there. What are we dealing with further up the chain? And that's where, with the history and what you had already done, really made my job so much easier. And then the next thing is me being able to see what you're feeling and what you're seeing and your dog's response. And I think that's what we're going to do now is, and this is, we're kind of telling a story, right? And this is exactly what Jana and I deal with athletes across the pond, the way we share cases and work with people, even from a standpoint of, performance longevity, is I need you to be engaged. So we see the history, we see the story, we see the videos, and now on camera, we want to see what you're seeing and feeling. So I know this is going to be totally off grid here, and it could be a complete IT disaster. And I'm probably going to make the IT guides and all the videos fall apart. And I apologize, but let's go ahead and go into your area, with Venom, and let me see you do a shoulder evaluation, of Venom, and let the people, watching or listening kind of see what we're seeing and hear what we're explaining that you're doing in case they're not watching on video. Yeah.
Okay. Sorry.
All right. I'm really excited. To look at
Venom.
you, Sherman, guiding Chiara through a home assessment that we also do with our remote clients. And we can do so much also across the pond. So yes, of course, there are limitations to remote work, but definitely we can learn so many things. All right, handing over to you.
Yeah, and you nailed it on the head. There's only, we can't offer a diagnosis. We're doing this remotely. We're not actually feeling the patient or the athlete. So we can only take the information that's given to us and educate them on what's given to us, right? But having a video like this where they can actually do the evaluation in front of me, many a times I'm doing this for a normal dog. I just want them to map their dog's body. I want them to know what's normal, so if something becomes abnormal, they can compare to normal. So even if Venom had no issues at all right now, I would want any owner to be able to do this with their dog, with me, so I can make sure that what they're seeing, they're doing it appropriately, like you do with the stretches. The active and passive stretches, massages, range of motion, same thing, same exact thing. So this is perfect. So the way that you have the camera set up is ideal. I do like to do these standing. Some dogs won't allow you to do these standing. You have to do them lying, and that's fine. I just want them comfortable. But from a standpoint of video's sake, for everyone that's watching this video, to see how we're positioning, how we're placing our hands, I think this will be really helpful. So the first thing we do is I usually have them standing, and I have them stacked, with the cameras directly straight on. And now what I'm going to do is I have Chiara get behind, we're just going to kneel down, and typically if we're doing a full body mapping, we'll look at toes and elbows and the spine and all that, but we're going to, for what we're focusing on today, it's the shoulder. So if you want to show how we would typically do a shoulder extension. So what's going to happen is she's going to hold with the left hand to stabilize the shoulder. With the right hand, she's going to get behind the elbow and push the elbow forward while holding, there you go, while holding that, there we go. So what we're doing here is we're locking out the scapula and actually moving the shoulder joint forward. If she didn't have her left hand where you see it, we'd be moving the whole scapula thoracic, okay? We'd be taking this, the scapula thoracic, versus the actual shoulder itself. So that was a beautiful extension. And if you look, we were comfortable. We didn't lick our lips. We didn't check in. Our eyes didn't dilate. We didn't hold our breath. So now if you can show us the flexion, same thing. So now we're going to grab the elbow, still stabilizing the shoulder in front of the elbow, and we're going to bring that leg all the way up into a nice flexion. That's beautiful. That's your supraspinatus stretch. Now, while we're there, she's going to bring the whole leg into an extension. So we're going to do what's called the bicep stretch. So we hold that leg up in flexion, and we're going to bring there. Now grab the paw, if you would, or the carpus. There we go. Now see how she's got it locked in flexion. Now we're going to do extension of that whole leg. So bring that leg back. Just keep pulling back a little bit. That's your bicep stretch. So this is 100% perfect. We've locked the shoulder out in flexion while now extending the elbow. That's a perfect bicep stretch. And look, Venom's looking around. We don't care. Okay, so now the hardest one. So we've done extension. We've done our lats, our teres. We've done our flexion. We've done our supraspinatus. We've done our biceps. Now we're going to do this thing called medial shoulder. And this is going to be the subscap, which is the number one thing that we engage when we're, doing these turns, when we're doing weaves. And it is important to give it love and to know what's normal for your dog. Okay, this is another stretch I need everyone to be comfortable doing. So now what we're going to do, get back to the same way you had the extension before. So behind the elbow and holding the shoulder stable. So that's perfect. So we fully extend towards the camera. Now bring the leg out while in extension at 45 degrees, right there. That is the most perfect abduction test, the most perfect abduction stretch. See if you can see, we're holding the elbow in extension, the whole leg's in extension while bringing it out, and she's stabilizing the scapula. Okay, so we're actually taking the scapula, we're holding that still, and we're moving the rest of the limb out in abduction at about a 45-degree angle while holding it in extension. So you are the poster child of the perfect dog and owner to demonstrate this. But that's what we would do. And you saw there was no spasm. You saw how far the leg went. And then we would classically go to the other side and compare and do the exact same thing. But thank you for showing the world how you actually do a teleconsult, real-time live evaluation of the dog's shoulder. That was perfect. Thank you.
Yeah.
Thank you, Chiara. Now you can reward Venom, and I would take this opportunity, Sherman, actually to go into anatomy a little bit, because I think it can be so abstract sometimes, thinking about what you are looking at and what actually is a medial shoulder. What do we think that is?
Okay, so what was really, really amazing to see, and what Chiara showed you with Venom, is how to appropriately do the stretch and to test these. So this is a shoulder. This is our shoulder model we were looking at. And again, this lives here on us. And we have the outside we call lateral. And there's two muscles that would be here. This is the supraspinatus, infraspinatus. The big guy that we're interested in, it lives in the entire region here. That's the subscap. And then we have this ligament right here called the MGL. So what I was really impressed with, and what so many people do wrong, is if this is the leg, they'll get behind it and they'll move the leg into what we think is extension. But if you think of that, you're just moving the entire scapulothoracic. So if you just move your whole dog's leg forward, you're not actually engaging at all the shoulder. So there's this little handle right here. We call it the acromion process. And what you saw Chiara do, came up to the shoulder, held the front of the shoulder. And now when we do that, you get behind the elbow. Now you're actually putting the shoulder itself through range of motion. Okay, we're not doing this. We're actually engaging the shoulder by holding the shoulder, this top part, the scapula. Now, when we do abduction, same thing. If we were just moving the whole leg, look what we're doing. We're not engaging anything. But watch this. When you held that top bone or top part of the shoulder, now look what we're doing. We're stretching those structures that live inside. We're actually testing, activating the medial shoulder. Okay, so we're putting that subscap into a stretch. We're engaging the MGL. But I thought that was so important, because otherwise, if you do this, look what you're doing. You're just bringing the whole leg out. So always make sure you stabilize the upper bone, and then you put the lower portion. And I use the elbow as a handle, right? I've just locked out the elbow. I'm using that as my handle to do all your tests. But that's how you do the appropriate, extensions, flexion, bicep stretch, abduction. So it was great to see you do it so perfectly. Thank you.
Thank you.
If you're okay, I would actually share a slide of that, and maybe you can explain a little bit.
I sure will. So the first thing is knowing where your dog's shoulder is. And I've had people feel here and here. It's so important just to know your dog's anatomy. And this is a way for you to bond with your dog, just doing massage and those gentle stretches and feeling what's normal. So the dog's shoulder, if you're not quite sure, Chiara did this beautiful job of bringing that leg up into kind of what we call shoulder flexion. The very front here of the dog's shoulder, then, the very front, that's going to be the front of the shoulder. Okay. So if you're not even sure where your dog's shoulder is, if you bring that leg up into flexion, just feel the front, you'll be like, oh, that's my dog's shoulder joint. So if you have a big Liamberger or something that's got so much fur, you can't even find it, just flex and you'll find the shoulder. Now, within the shoulder, we have structures that live on the outside of the shoulder and structures that live on the inside of the shoulder. Outside is what we call lateral. Inside is what we call medial. So this whole thing, when you hear this term called medial shoulder something, whether they're talking about syndrome or instability, and we'll talk about the difference, medial simply means you're feeling up inside. So think of like your own armpit. Okay, so we're reaching up inside our area, up in our armpit or feeling those structures. That is the area of the medial shoulder. So what we're looking at here in this schematic is a couple things. We're looking at the skeleton of the inside of the shoulder, and where this area is right here, where this arrow goes, that's called the subscap muscle. And it is a huge muscle. And if you think about it, the opposite side of that bone, called the scapula, has two muscles, what's called an infraspinatus and supraspinatus. But Mother Nature thought it was so important for the muscle on the inside of the shoulder, it was an entire muscle. So the other side has two guys to make up for the one we have here. So that tells you it's doing an important job. If the entire inside of your scapula is a muscle, it's got an important job. And what is that job? That job is to bring the leg back in under the body. Okay, so that stretch that you saw Jared do with Venom, that's to stretch that muscle. Remember, so if the job of it is to do this, the stretch of it is to do that. Okay, so what's going to happen is that at speed, whether you're going through weaves or you're doing a turn, Mother Nature says, hey, my job, I'm turning, I got to bring that limb back in and collect underneath my body. So that's what the subscap does. Now, lower image, you're going to see here in this cartoon, the arrow is going to this thing that looks like a thing called a ligament. And that's what we call the medial, meaning again, inside, glenoid, meaning ball and socket. The shoulder is just a ball and socket joint. And so glenoid is just the sort of the socket part of the ball. And ligament, just like your ACL in your knee, or what we call a CCL in a dog, this ligament is the ACL of the shoulder, if you would. So basically, we have two big structures that live inside the shoulder that are responsible for, hey, I'm turning at speed. I got to keep myself strong, bring that leg back in, keep it stable and functional. And those are going to be the subscap then and the MGL. Now, there's other things. You have your biceps and your capsule and all these other structures, but the two big ones are those guys. And the reason I called it, many, many years ago when we wrote the textbook on medial shoulder syndrome, I took it from the word instability to syndrome because these shoulders aren't unstable. The ball's not falling out of the socket. Okay, we're not seeing that at all. We're seeing a slow breakdown, deterioration, like a domino, where the MGL, the subscap starts to go. It's not, you basically have this, what we would call neuromuscular inhibition. It's not functioning. Okay, it's not turning on. MGL has to take over. Capsule, your biceps, all these other structures have to engage because the subscap isn't doing the job it was supposed to do or isn't doing. So that's where we turn it into this, I called it a syndrome because it's a domino. Once one goes, everything starts to have an issue. But anatomically, that's what we're dealing with. So hopefully that makes sense.
All right. And what made you then recommend further diagnostics? So we are still in the telemed consult, but you also saw Venom in live, and we are going to go there in a minute. But before that, what made you click, oh, we really have to investigate deeper?
Yeah. So I hate this term soft tissue injury. We're much better than that. This isn't 1980s medicine anymore. So we can say we can not only get a diagnosis, we can get an exact diagnosis to the pinpoint of where the injury is. But we want to take it simple and make sure we're not missing anything. I tend to be a little bit type A, obsessive compulsive when it comes to diagnosing things because there's so many variables and many times there's many components. And if we take a step back, Rocky Mountain spotted fever, you had that point there. In the United States, I can't say how it is across the pond, but in the United States, tick-borne diseases right now, especially even this year, the reports are they're the highest they've ever been in dogs and in people. And so many a times I'll have a dog that comes in that just seems off. they're not limping, they're just off to the owner. Their times are down, they just seem a little bit not right, not on. And so with that, many of these tick-borne diseases can cause that. We see Lyme's disease, Ehrlichia, anaplasm. More importantly now is Rocky Mountain spotted fever. We're seeing that more than anything. And so when I have a dog that just sounds off, the first thing I do is I'm like, let's just make sure those are negative. That is part of my sports assessment anyway. I'll have owners that say, but I live in a state that we don't have ticks. There is no state that doesn't have ticks. And oh, by the way, don't you travel? Yes, you live in Texas, which they have Lone Star tick, but you were just in Maine where we see every tick, okay, or North Carolina at a trial. So I made sure that we tested Venom for the big ones, Lyme, Ehrlichia, anaplasma, and Rocky Mountain spotted fever, because sometimes we do a treatment of a dog with some injury, or we're rehabbing them, and they're not getting better, only to find out, oh my Lord, they had an underlying tick-borne disease that was creating inflammation throughout the body or stiffness. And we can't get on top of it unless we treat the whole dog, the whole body. Sure enough, Venom was positive for Rocky Mountain spotted fever. Does that mean it was the cause of the issues? No, not necessarily. Many dogs just have that in addition to other things. But what would be horrible is if we put Venom through all this rehab and all the retraining and getting back to sport, only to find out that, oh, the reason we're not 100% is because we had an underlying Rocky Mountain spotted fever issue. So it's a very simple test. We run titers. We don't do what's called a snap test because it doesn't have Rocky Mountain. So your veterinarian will send this off to a lab. Within about a week, you get the titers back. And Venom's Rocky Mountain spotted fever titer is really high. So it's simple doxy. So doxycycline helps to knock that out. We retest titers down the road, make sure that we've actually officially cleared. But yeah, that's so important. So annually, anyone listening to this, please make sure when you go into your vet's office for the annual assessment, or you see your sports med specialist for their, we call it race ready assessments. I want to make sure they're adding tick assessments, tick panels, titers into that workup. But to answer your question, the next step with diagnostics is radiographs, or what we call x-rays. I take them to be complete. We know it's quote unquote this 1980s word soft tissue injury, but maybe there's an old shoulder OCD. Border collies commonly get shoulder OCDs. Maybe it's a mineralized tendon, which Venom did have in one of the tendons called the supraspinatus. Maybe there's arthritis. Maybe there's a fracture. So we have to be complete. And when you take an x-ray, you always take the other leg to compare, because many times we'll say, oh, that's it, look at that, and it's the same on the other side. So here's an example of an x-ray, and what you're looking at, and this is what I always ask veterinarians, please always do the left and the right to compare, so that if we see something, we're like, oh, look at that, there it is. We're like, oh no, it's the same on the other side. So you always do that, and you take two views. So this is what we call a side view or a lateral view. And then we would have veterinarians take what we call a front view or cranial caudal or anterior posterior view as well, because you want to see things in as much of 3D as possible. And I always get x-rays from the toes to the shoulder, because just like in Venom, there can be a digit issue. Let's not forget that. We're focusing so much on the shoulder. Why can't we get better? Oh, we missed that digit arthritis, that toe arthritis. Okay, so when you're having your veterinarian take x-rays or radiographs, please start at the toes, work your way all the way to the shoulder, front view, side view, both legs. But in Venom's case, the x-rays were pristine. Yeah.
So fast forward in time, or not that fast forward. What did you find during Venom's assessment? So he came over to your office and you probably made some other tests. So what did you do?
Yeah. So the first thing we do in the sequence of, Venom's, saga, if you would, or novel, is we had our telemed, we had the assessment online, we had our tick titers, we had our radiographs. The next things we'll do is a gait analysis. Okay, so we actually want to gate them. Now, I've already gated by looking at them in the ring. I take them out literally to the parking lot or out to the grass. I want to see them move naturally. But then we rely on objective outcome measures. And we have it in California at my California location, and on the East Coast, at the East Coast location. That is a long mat. It's like 50 feet long, and there's millions of little sensors in there. And they will give me so much information. They tell me how far are we striding. So we call this a stride length or a step length. And if you and I are hiking, if we reach this far with this leg, we should reach that far with that leg. So the lefts and the right should equal, the front to back should equal, cross pattern, ipsilateral should equal. So it will show me stride length and step length and ratios, and it will show me pressures. So for instance, if you have arthritis in one little digit, you're not putting full pressure on that leg. You may look fine to the owner, the handler, the veterinarian, the specialist, but your gut says, I don't think we're placing full pressure. And sure enough, there's a thing called TPI, which is total pressure index. And it simply means how much pressure are you placing? So we should be, in a typical border collie, 30, 30, 20, 20, because 60% of their weight is up front, 40% is in the back. So if I'm having a dog come in for just a normal sports assessment, I want to gate them so they know their dog's normal. What is their normal stride length? What is their normal pressures? And in Venom's case, if we look here, this was us going down the mat. The mat is at the very bottom. All these different colors are coordinated and associated with the different feet patterns. And so you can see the front legs, the back legs, different colors. And then we look at all this data. There is a ton of data, but in this particular case, we're looking at what we call the TPI and how much pressure we're replacing. Well, look at this. We said, well, we should be 30-30. This doesn't look bad. Venom's 31 on the left. Wait a minute. We're 36 on the right. Venom is taking the load and putting the majority of the load to the right forelimb. Okay, we're not balancing appropriately. In fact, Venom was off in all four quadrants, really. And so, but you can see the majority of the load for Venom was coming into that right forelimb. That should only be 30. Why am I concerned about that? I'm more concerned about this than the other leg because that right leg is taking all the load now. I know that out there in the ring, even just hiking or running around chasing the squirrels in the backyard in Michigan, we are loading that right forelimb. And that means that one's going to start to head south on us if we don't get on top of this. It also tells me if I'm going to evaluate the left, I best look at the right because this guy's probably been taking some load for some time. So we see that the pressures aren't normal in the front legs, with the left being most significant. And then our stride lengths and our step lengths and our ratios, they're not equal. So we're not reaching the same front to rear. We're not reaching the same or stepping the same left to right. So there was a lot to evaluate right here. But the important thing with this is we now have a baseline. So whether we do, chiro, massage, shockwave, laser, some sort of injections, surgery, scope, whatever, I want to see those numbers go back to normal, okay, or go back to as close. And that way, objectively, we know we're hitting those marks, that we're getting closer and closer to where we should be. Okay, so that's the next thing we'll do is objective gait analysis. We have our radiographs, and then classically we say, oh, it's quote unquote soft tissue injury, let's do an MSK ultrasound. So many a times that's our next step. And look at that, you have an ultrasound. So what we're going to do now, this is very, so, if you think of sports medicine, we are so behind in dogs compared to horses. Sports medicine and horses and humans have been out for so long. And if you have a horse with a lameness, what's the first thing they're going to do? They do their flexion test, they're ultrasounding. Right? They're looking at the joint with ultrasound. They're looking at the tendons with ultrasound. And so ultrasound, not only can we get a nice image, we can do this dynamically. So what you're looking at in this video, so for those of you that are listening but not watching, we're showing a video clip right now of an ultrasound looking at the medial shoulder, and we're placing that shoulder into abduction, okay? And so we can see, are these tissues engaging? Is there inflammation there? Is there any signs of disruption to those tissues? The nice thing I like about ultrasound, we can do these awake. We can do them, left to right, so we can compare normal to abnormal, or see if the other side's starting to get some, early breakdown. It's less expensive, and it's something we can come back to and do time and time again. You're not going to say to a person, oh, let's MRI both shoulders just to compare, or every 30, 60, 90 days, let's re-MRI or CT. Plus, those are static, not dynamic images. So MSK ultrasound is our go-to. Challenges in our planet, finding people that are trained that can do MSK ultrasound and that have done enough cases that feel comfortable looking up at the medial shoulder. There's people out there, but that's something that would be the next step in my hands, is to say, how does that medial shoulder look? And if I say, hey, on gait, we're doing this, on palpation, we're doing this, on ultrasound, we're doing this, then I say, the next step may be to take a teeny, tiny little needle that has optics, slide that into the shoulder and get your definitive diagnosis. We call it a needle scope, because that's like scuba diving. You can't miss it. If it's there, it's there, and we know what it is, and we can treat it. If we get in there, it takes 1 nanosecond to look. If it's normal, we're right out. They don't even know we're there. So that's the series of diagnostics, if you would, that we typically use for these medial shoulder cases.
So you literally go inside the shoulder.
We're going inside the canine athlete.
Wow, what if you walk us through what you can look for in the shoulder?
Yeah, no, absolutely. So when we are doing this, the scopes that we use, if you think of size, it's 1.9 millimeters. So these things are teeny, teeny, tiny. We're going to go into the side of the shoulder. It's you do have to shave a little patch. It's aseptic, it's sterile. So you're going to go in and we're looking at everything, the cartilage. We're looking at the joint. Think of the joint. It's a water balloon that keeps the fluid in there. We want to see how much inflammation's in there, and we want to look at the structures. So here's a video, and we'll play this a few times. Cartilage is this beautiful white looking structure here. This is like an eggshell, right? It looks beautiful. There's the top surface, there's the lower surface. That in the background, that's the joint capsule. Think of it like a water balloon. Okay, so we can play this one more time and walk you through again. The front of the shoulder, we always start in the front. That's the biceps tendon. It's nice and smooth and crisp. We work our way back. This is the subscap. This is the most important tendon of the dog's shoulder when we're talking about medial shoulder. Above it's the ligament called the MGL. And this is the capsule. It's smooth. You see blood vessels here. That's normal. And that's what we should see. Okay, so that's your typical normal shoulder.
What if it's not typical?
Okay, so this is your classic shoulder that's not. This is your average typical border collie medial shoulder. There's a beautiful tendon there. As we work our way back, look where the cursor is right here. That's tendon that's normal. There's our tear. So you guys can see there's a tear right here above where it attaches to the bone, to the cartilage area. This is your subscap, okay? It should be nice, fine little lines like you saw a second ago. We'll play this video again. But what happens is there is beautiful there. See how it's like little feathers, little hairs. That's normal tendon. Work our way back. There's the area of disruption. This is what we would call a grade 2 tendon tear. Now, it looks horrible, right? You're like, oh, my Lord, it looks like something exploded. Remember, this is everything's under high def light. It's magnified. But that gives you an idea of what we should see versus what we see in the classic. If you say 90% of the medial shoulder cases that we see that are agility dogs, this is what we're going to see right here. 1 being normal, 10 being the worst I've ever seen. This is your typical 5 or 6, right in the very center. Now, we talked about the domino effect. When the subscap starts to fail, okay, and we have that neuromuscular inhibition, we would call it, the next structure has to take over, and that's the MGL. So this is the ACL of your shoulder, if you would. It's a ball and socket. So this is the socket above. That's the scapula or the glenoid. Beneath it was the ball or the humerus. So if we play this video again, when I put this shoulder into abduction, so extension with, abduction, we're engaging this ligament. You can see the tearing that we have. This is a grade 2 to the MGL. Okay, so this MGL is working overtime now because of repetitive activity, but also in many of these cases because the subscap is just not engaging the way it should, it's not activating, and therefore the MGL has to work overtime.
So if we're thinking now back to athletes and back to agility athletes, I have to play this.
Okay, this is the most important slide that I've ever created. And we're going to spend just a few minutes on this. So for those of you listening but not watching, what we have on this slide is a picture in the top left corner of me taking my own border collie. This was Enzo, and I'm putting Enzo's shoulder through an abduction stretch. So it's exactly like Chiara showed us with Venom. We lock out the scapula, we get behind the elbow, we extend the full limb, and we bring that out to the side in abduction. Now, I want you to understand now the lower pictures that you're going to see to the lower left. For those of you listening but not watching, this is a picture of a dog going through weave poles. And if you look at the position that I have Enzo's shoulder in, testing an abduction, it is identical to the same position we see going through weaves. Okay, so you can see now, and imagine now that was also just a turn. That shoulder is in that same exact position. So everyone memorize that position of that border collie's shoulder compared to the top left where I'm feeling the structure. Now, how do we know that that engages the medial shoulder? What you're looking at in the top right, so for those of you listening, not watching, I'm showing an arthroscopic or needle scope image of me placing a dog's shoulder into extension with abduction. So I'm doing the medial shoulder test. What you're seeing is the top is the glenoid, the socket, bottom is the ball. And I'm stretching, the tissues that you're seeing here being stretched are the MGL and the subscap. Look at how when I bring that shoulder out to the side, you can see the amount of stretch or pulling of those tissues. Now imagine when these dogs are doing this thousands and thousands and thousands of time, you're going to start to get some wear and tear. And that's okay. Every sport has wear and tear to structures. But imagine if you're doing that and you're offline. Imagine if you're doing that in the artificial turf that you're on just isn't giving you the grip that you should, or you're overtraining. These are things then that we start to see these things start to break down, of course. And the reason why I wanted this scope image in here is to show you I had to figure out how to test the shoulder in that position. And I didn't know, was it just extension engaging it? Was it out to the side engaging it? Oh no, it's extension locking out the limb with it out to the side at 45 degrees. I did that with a scope and I was like, oh my Lord, this engages all those structures. And then I started looking at picture after picture and video after video of dogs in many sports saying, when does a dog have its leg in that exact position? And it just happens to be weaves and turns for this particular sport. And if we're talking about fly ball or dock diving or anything else that could happen, say they're even on the dock and it's slippery and it's wet and that leg slides out. Oh my Lord, where does it slide out? In the same position, hardwood floor or tile in a person's house. And they think it's funny that the dog's just running around the kitchen chasing the other dog and the legs are going out like they're ice skating. We're engaging the same structures. So I'm not just beating up on agility here. I don't think there's a dog or a dog sport out there that they don't bring that shoulder into that position. Okay. Even for the house pets. So that hopefully that makes sense to everybody, but this is how we know how to stretch it. This is how we know how that shoulder in position in the ring or in the backyard actually goes into that motion to engage those tissues. Sorry, that was a lot to unpack, but I think it's so important and it really tells the story of how we identify it, why it's happening, and how we can truly diagnose it.
So back to Venom, Sherman. What did you find out?
Whew. Yeah. So what we found out, we saw the gait. Okay. We heard the history. We saw the gait analysis. We weren't putting full pressure. We weren't striding. On palpation, what I felt during the exam that day, when I would engage and do the abduction test, same thing that Chiara was getting, there was spasm. They're not going to cry. What we're not going to see, we don't see them cry. They don't try to bite us. Pupils dilate, they check in, they hold their breath for a second, they may lick their lips. But what I'm feeling is, how is that shoulder feeling when it goes out to the side? And I'm okay if it goes out to like 60 degrees and it's comfortable, as long as it goes out to 60 degrees and it's comfortable on this side, right? But if it goes out to like 40, a little bit more degrees on this side, and I see spasm, involuntary spasm, or we hold our breath, or we check in, or we say, I'm kind of feeling that, or it just feels weak and Venom's not able to pull back from me, okay? And I go to this side and we're like, it's like 20 degrees. I feel pretty comfortable. I'm just looking around and I feel it engaging and it's strong, okay? What do I mean by that? So for any of you out there, we'll do a couple different tests. If you go to your own chiro, your own physio, they'll do a test for your rotator cuff where you're going to take your arm and you're going to hold it out like this. And they're going to try to just push against you. And what you're going to find is on the side that's strong, oh man, you can fight them, right? You're holding that up. And over here, and you're like, oh, I'm going to fight them. I'm not going to let them. And all of a sudden it's like, zoop. And you're like, what in the world? And you bring it up again and they're like, whoop. And you're like, how are you doing that? You're not activating. Okay. It's not that you're weak. It's turned off. Okay. Your neuromuscular activation or inhibition's kicking. You don't have it. It's the same test. I know when we talk about iliopsoas, for any of us that have a weak psoas, it's a hip flexor. So we're going to bring our leg up and our physio or our chiro or our sports doctor is going to try to push down on that leg. And boy, we're engaging it. And they go to our other hip flexor and they try to push down. And it's like, we can't even fight them. We just have an issue there. It's deactivating, right? It's inhibited. So that's the same thing we look for. When I was looking at Venom's shoulder, I said, okay, on this left side, well, we go to the right side. Okay, it's going out. It's about roughly 20, 30 degrees. It's comfortable. Maybe a little mild spasm is what I found when I went back and looked in the records, but we were engaging. I went to the left side and I was going out and it just kept going. And Venom's looking at me like, I feel that, but you could feel there was just no nice resistance to it. There was no end feel. It was just not engaging. Okay. And Venom wanted to engage, was not engaging. So it wasn't necessarily a strength thing. It was an activation thing as well, where something says this medial shoulder is not doing what it's supposed to be doing. But hopefully to the listener, that makes sense. Very similar rotator cuff tests that they would do in us in people. Very similar response. So that was enough to me to say, based on the findings with diagnostics, based on the findings on exam, your history, gait analysis, we need to put a small needle scope in there. And when I did, we said, hey, you know what? I'd like to look in the left shoulder, but I definitely want to look in the right shoulder. Okay, because my fear, this has been going on for a while. We know these guys can compensate. I know that 35 to 50% of the time when one shoulder has it, the other shoulder definitely has it early on, or if not advanced, because of compensation for years. So I said, I'd like to look in both. And we're like, okay, let's do this. And so I took the needle scope, I slid it into the left shoulder. Sure enough, the subscap had a grade 2. Sure enough, the MGL was breaking down. Sure enough, there was inflammation in there. Your classic border collie finding of a dog that's a high drive, international level dog that says, I'm fine. There's nothing wrong with me. I'm going to continue to use the wall as a way to stop. That's normal for me. In the opposite shoulder, it was going the same direction. Okay, we saw a grade 2 to the subscap. We saw a grade 2 to the MGL. We saw inflammation in the shoulder. So I was so glad we looked. I was so glad we looked into them. And then we treated both. Okay, so if you're there, the nice thing about looking, you not only get 100% definitive diagnosis, but you can treat at the same time. Okay, and so we use a combination of treating these with needle scope, arthroscopically, and we use orthobiologics. And that's a big word for things like injections of a product into the joint to help the body heal itself. Those things can be platelet-rich plasma or PRP, which we know Venom had already had a few PRP injections, all the way up to even what we call stem cell therapy. So there's a whole host of things that we can inject into the joint, even hyaluronic acid or HA, something that can help to lubricate the joint and be somewhat anti-inflammatory. So those are the ways that we diagnose those, and those are the ways that we treat them.
So Chiara, how did it feel when you finally had an answer? Like, was it a relief, scary, both?
Both. It was obviously like, okay, finally, after so many months of like, what is going on with my dog, at least we had an answer. Maybe not the answer I wanted, right? Who would? And so it was a relief. It was also very scary because, like, what's going to happen now? Like, right? I mean, we all know in humans too, you can have the same surgery and then people recover different ways. So, I had all these hopes and dreams for him. And I'm like, is he ever going to recover? Is he ever going to come back at running agility? How, when, you never know. So both, definitely both. There were lots of crying, but mostly, I guess, everything Dr. Canapp said made sense. And it like closed the circle, right? Of like all of these things that I obsessively went back and looked and found and analyzed. And then he finally like gave me an explanation of like, I think this is the problem, right? And these are, the signs you would have seen in the dog, blah, blah, blah. So it made sense. So I guess as much as it was scary, I also thought, straight up, even forget agility, quality of life when he's going to be older. And, I still want to be able to take him for walks. I still want him to be able to just, live a normal life. I live an active life. So I wanted my dog to be able to do that, especially based off of his character, right? He's sure not a dog that would be okay to just lay on the couch. So even if it wasn't for the agility, just to give him a good life, quality of life, I thought it was the right thing to do. And I'm glad I did it. So.
And that, I believe, is why your part of the story is really so important, because you knew Venom, you noticed the small changes, you kept asking questions, and that eventually led to a deeper look and also a clear diagnosis. So for everyone listening, the message is not that you need to diagnose your dog yourself, but that your observations matter. And all these small changes you notice in training, in competition, in daily life even, they can be an important piece of the puzzle. And if this episode made you think of your own dog, like maybe a moment where something felt off, a change you would not quite explain, a performance problem that did not make sense at first, we would love to hear from you. And in the next part, we will continue with what happened after Venom's diagnosis. So the treatment, the hobbles, the rehab, the setback that we had, and the long road back to sport.